brain death, abortion, and the so-called personhood law in the state of Georgia. That and much more on this episode of All Things Women's Health. I'm an obstetrician gynecologist of more than 30 years. I'm a husband, I'm a father, I'm a grandfather, I'm a small business owner, I'm a Catholic, I'm a lot of things. But right now, I'm your host as we talk about all things women's health. Everything from menstrual problems to migraines, mammograms, to menopause, homeschooling curriculums, to personal training curriculums. If it affects women, it's on our agenda. And our agenda today includes a complicated topic, and I'll start off with maybe a bit of a triggering warning. We're going to talk about abortion. We're going to talk about brain death. We're going to talk about removing life support. These are difficult and often very emotional topics, but we're going to try to work our way through that. And helping me is someone who knows much, much more about this than I could ever know. Father Ryan McCarthy. Father Ryan McCarthy is the pastor of Holy Rosary Catholic Church in Indianapolis, and he has so graciously agreed to join us today. Father McCarthy, thank you for coming.
You're welcome. Pleasure.
It's great to have you. This is a difficult case, and I mean, I think as our discussion evolves, it'll become clear that it's difficult on a lot of different fronts, so to speak. But part of the challenge is incomplete information and misinformation, and then, of course, perhaps our colleagues in the media may have been trying to spin the story in certain ways that are not exactly authentic. But at its face value, I think I would say. The story goes something like this. Adriana Smith is her name. She's a patient at Emory Hospital, Midtown Atlanta. She was a nurse, interestingly. She went in with a headache and some other details that aren't altogether clear. At the end of it all, she suffered what sounds like a massive brain aneurysm and became unresponsive and was labeled as brain dead. We're going to talk about what that label means and doesn't mean in a minute. To make this story more complicated, she was also, I believe, about 9 weeks pregnant at the time. And so the administrators and the medical team and those caring for Adriana at the time determined that they were unallowed to allow her to continue to die. I'm not sure that's the right phrase, but we'll get into that as well, because of the so-called personhood law in Georgia, which is a law that says an abortion is illegal anytime after the fetal heart rate can be detected on ultrasound, which is around typically 6 or 7 weeks. So they intervened and said, we can't intervene because of this law. Her parents, as the story goes, or her loved ones who were responsible for making medical decisions for her, wanted them to intervene and discontinue life support. Now, this is approximately 9 weeks. She's now roughly 23 weeks pregnant, meaning the baby is peri-viable, as we would say, or around the time of viability. So now, presumably, this woman is going to be kept alive until the baby can be delivered. And it's a very unusual case. And as you can imagine, it's charged with emotion and conflicting sort of agendas. But I guess maybe, Father, the first thing we probably talk about is this word brain death. That's not an easy one, is it?
No, it's not an easy one at all. As you can testify, in the medical world, there's no exact agreement on what brain death is. I think everyone would agree that zero anything on a EEG, which is a measurement of electrical activity in the brain. So getting a zero across the board on all those is probably a safe definition of brain death. But I don't think you would get the entire medical world to agree that that is the extreme necessary to consider someone brain dead.
But that would be probably the cleanest, for lack of a better word, definition, wouldn't it?
Yes.
So a patient...
You could speak more to the medical than I could, but that's what I would see.
But as far as this case goes, or a case like this, we would say, for sake of argument, no brain activity on an EEG. The brain appears to be dead. The patient has a breathing tube in. A ventilator is breathing for her. She lacks the ability to continue being alive without, mechanical means.
Intervention. Yeah.
So if that were just the story, and we didn't bring in the complexity of the pregnancy, if that were just the story, and I were her medical decision maker, This situation comes up with people having to make decisions, I think, for elderly parents, not uncommonly. Um, what are the ethical issues, and where does church teaching guide us on if we're making decisions for that elderly parent? How do we go about doing that?
So the general rule that I kind of apply, this is kind of like uh, the summa of the summa of the summa of medical ethics. Everyone should die of what they're dying of. So we have an amazing ability in the modern medical world to sustain life, to keep hearts beating, to keep lungs breathing with or without any autonomic function, like without the body doing it on its own.
Mm.
But at some point in time, everyone's dying of something, and you should die of what you're dying of. So if you're dying of a massive brain aneurysm, at some point in time, we let that person die if we can't heal them.
Mm.
And so the church would have no problem with drawing the life support and letting that person die of what they're dying of, because that's going to happen eventually. So you're just extending the dying period because from what we can tell from the case, she has no ability to recover from this injury, and she has no ability to continue living. Even on life support, eventually the body systems break down if she's truly brain dead.
Yeah.
And she won't be able to control function of body temperature, heart rate, all those things will start falling apart.
Right.
So you can just let that natural process take its normal course, and there's no moral issues with that whatsoever. Because dying of a brain injury.
Should we differentiate, or I guess I should say, could we differentiate, a case like maybe the very famous Terri Schiavo case where it isn't brain death for most definitions. I think it was called persistent vegetative state. She didn't need a ventilator. She had no activity. Her brain was showing activity. She could breathe on her own. But
she wasn't actually dying.
Right.
She was not actually dying. And so anyone who's not dying, the church says, in the Terri Schiavo case, it was a matter of whether they should provide nutrition and hydration, even if by artificial means. And the church actually has been very clear on this. John Paul II was very clear that someone who has a brain injury but is not dying of a brain injury, which is Terri Schiavo, has a right to receive the most basic level of care, which is nutrition and hydration, because no one can live without nutrition and hydration. So she should not have died of starvation or dehydration. She should have died of whatever she was going to die of. And so by withdrawing nutrition and hydration, she wasn't actually dying of her brain injury. She was dying of starvation/dehydration.
Yeah, so really radically different, but yet it would be easy to commingle these kinds of cases. And I've seen some in the media sort of do that.
Superficially, they can look very similar.
Yeah, but in fact, they really aren't, are they?
No, because you can be on a heart-lung machine for a long time, not a long, long time, but a relatively long time, in order for them to bypass function to repair something. And you're not functioning at all, really, at that point in time. I mean, your body's on ice, and then they're reviving everything as a means of curing you. And you could be theoretically considered clinically dead because you're not breathing and you're not circulating blood, right? Something else is doing that for you. So it's a huge amount of intervention, but there is knowledge that the body is going to have the capability to heal and continue on. And so that's a much easier understanding of how you justify that level of medical intervention versus if someone has no ability to recover, then you're just keeping them alive you're not actually keeping them alive, you're slowing the dying process.
Oh, sure. I'm sure in your pastoral role that you've had to help family members and families through this painful process of dying like this.
It is terrible. I mean, because there's so little education, so little knowledge of it.
Yeah.
What is probably the most difficult thing is when people are on some sort of mechanical intervention, some sort of respirator, whatever other things are on, and it becomes clear that's no longer going to provide an opportunity for healing or any real benefit, and it has to be withdrawn, and people feel like they're killing or murdering.
Right.
Versus, and people feel and see this as a big distinction. Morally, it is not, versus never putting them on any of those things to begin with. And so they think if they never put them on, then they won't have to kill them later.
Oh, gosh.
But the reality is that you can put someone on, or you can give someone a treatment like that and then withdraw it when you realize it's not providing benefit, that they're not going to be able to heal, that their bodies still continue to die and shut down. So,
And I think this discussion comes up, or at least it should come up, when family members are trying to write maybe living wills, describing what they want. I mean, maybe you would not want to be sustained forever on a ventilator, but maybe you being on a ventilator a day or two to allow your pneumonia to heal, you'd be taken off the ventilator and you would be fine. So
yeah.
you wouldn't have to not be intubated because you didn't want long-term ventilation. But that is confusing.
And my recommendation is everyone needs to educate themselves on these issues for sure.
Yeah.
And then as far as living wills go, I think it's much better if you have a power of attorney for healthcare purposes.
Sure.
And talk to the person who's going to be in charge of your healthcare and give them the decision-making power, rather than living wills can put the decision-making power in the hospital or the doctor's hands versus in your loved one's hands. And
Yeah.
doctors and hospitals don't always have the same ethical, moral outlook that the patient would have.
Yeah. So to be clear, and I'm no lawyer, I don't want to mess it up, but when we say a durable power of attorney for healthcare, I'm saying to my spouse, for instance, you make decisions for me. You know what you know what I would want. You don't do what you would want. You do what you think I would want, as opposed to.
It would depend how you wrote the power of attorney.
Mm-hmm.
Because you could write it and just say, use your own judgment. Done.
Yeah, that's easy.
Yeah.
And then you would presume that you'd had these talks and this person would be acting in your interest. And if you don't think they would act in your interest, you shouldn't make them your power of attorney, I guess.
No, and I don't know. I presume that doesn't exist, or they would have brought it up already in the case we're talking about. But that would also have been very helpful guidance for the family and doctors in the case that is there right now.
Yeah, absolutely. So that would be an important distinction to make. And I'm sure all too often, especially with young people, because young people think they're never going to be in that position, that it's not done. But that would be very important. And then the family member could just make decisions in the best they could. As opposed to in a living will, it may say, don't put me on a ventilator. And then a hospital could use that to say, we're not putting this patient on a ventilator, even though it could be that temporizing thing that I talked about. And that's where conflicting values and views and motivations could come into play, I believe.
Yeah, a lot of them.
Yeah. So that would be perfect. So, I mean, in fairness, have you, I believe it was Mother Teresa that used to pray, may you have a good death. But have you been in a position where you've witnessed the opposite and seen things go well in these kind of troubling times?
In regards to people on...
Yes, family members working their way through these issues.
I think when they bring in... So there's all types of distinctions. It's sad in the world we live in. There's all types of distinctions in the type of medical care and the doctors that are trained for the medical care and what they do.
Yeah.
But I think when you have a good palliative care team that has a good understanding of morals and ethics, even if they don't necessarily share your morals and ethics, but they can come to understand what your morals and ethics are. I've seen a lot of very positive, very beautiful, very healing experiences around these dying times, like when people are dying and people are making these hard decisions, and you have a good doctor who understands and helps you make those decisions. Palliative care teams can be really helpful. I know as a priest, I'm not a doctor. I know a lot about medicine. I often say to my friends, I'm a really good fake doctor because I've been doing medical ethics for 25 years now. So, I mean, that's what the bishop sent me to get my doctorate in. So I do this, and I'm familiar with a lot of difficult cases because those are the ones that get referred to you, but I'm not a doctor. So, I can't tell you what dose of morphine is appropriate for what person at what stage in dying, depending on how long they've been on morphine. Mm-hmm. But a good palliative care doctor can, and let you know what they're trying to achieve and how they're trying to achieve it, and to keep someone maybe comfortable but alert if that's what they want. Mm-hmm. And to determine, like, is there any real hope of healing here, hope of someone recovering, or is it actually just the dying process going on? And it becomes very difficult, particularly when you're talking about long-term Alzheimer's, dementia, Parkinson's diseases that have at first primarily effects on brain function, but then later on actually affect the whole body, and trying to navigate that path of Are they not eating because they're not hungry because they're dying, or they're not eating because they're not being fed?
Oh, sure.
You know,
Because loss of appetite is a natural part of dying.
yeah.
Yeah, interesting.
And when someone's dying, I mean, I remember saying to someone who was worried that their loved one wasn't eating enough, and when they're in bed and they're not doing anything, when they're relatively inactive, and you're 80 or 90 years old, you don't actually need a lot of calories. So they were saying to me, well, they drink like 2 milkshakes a day. I'm like, well, that's actually probably enough. Like, they probably don't need a whole lot more food than that if they're living a pretty sedentary life, or in a
Sure.
completely sedentary life.
It's a bit of a tangential move, but I think related to a degree, and that is organ donation and the circumstance where it's been determined that removing life support is appropriate. The family wants that. It makes sense. It's an ethical choice, and the person wished to be an organ donor, and so it can become necessary to keep the person alive in order to allow their organs to be removed, and then they're allowed to die after the organs are removed. Are there difficult issues to work through there from an ethical standpoint?
The question's always going to be, what is brain death? Is it total brain death? Because the church allows the donation ex cadaver, so from a cadaver, right? Like
Yeah,
from an actual dead body, not from a living donor. And it's a lot of times those decisions seem to be rushed, and they're trying to get the organs in as good a shape as possible.
sure.
So I'm not sure that there's complete flatline EEGs in those cases
Yeah.
always.
And that's
That-
probably a great example of conflicting motivations, isn't
yeah.
it? Um,
And so, but it's actually not a bad analogy for the case we're talking about. I mean, it's a bad analogy that a person is not an organ, but a baby is. You're keeping the cadaver alive, as it were, which is kind of that weird place, right? You're keeping the cadaver alive for the sake of the organ and organ donors. You're doing it for the sake of the baby who's being gestated in the case we're talking about.
Yeah, so that takes us back to Adriana Smith. So they discover that she's 9 weeks pregnant, and as I understand the story, the hospital intervened, as I mentioned in the opening remarks, and said, "No, we can't withdraw life support." I believe they've since said that was a misinterpretation of the Georgia law, that they could have, if not should have, followed the parents' wishes and withdrawn support. But now, of course, the baby is approaching or has achieved viability. Now it becomes a much more complicated issue. But if we just go back to that day, and with some assumptions, she was 9 weeks pregnant. If we assumed she had an acceptable definition of brain death, what are the issues for withdrawing support and allowing her to die, knowing that she has a live baby inside?
So the question would be kind of double effect question.
Yeah.
So is allowing the mother to die, or if she's already dead, not providing support to her, morally evil? The question is no. Are you directly killing the baby as a result? I would argue you're not directly actually killing the baby as a result, because you can intend to withdraw that support without intending the baby to die at all. You could, at 9 weeks, obviously there's nothing you could do,
Yeah.
but you could do everything you could to save the baby, and it's still hard, but the baby will die. So, I mean, sometimes this happens, and babies die in double effect cases all the time.
Maybe we should pursue that a little further for our non-bioethics listeners, this principle of double effect, because it's so important. Walk us through that a bit.
So double effect is when you have one really external action with two effects. Probably the most common case you run into is probably ectopic pregnancies.
I thought you would go there.
Where we have a baby who is gestating in the fallopian tube, and as we've discussed in past cases, not this case, but past cases, oftentimes those can actually be resolved by just waiting and monitoring, and they move very quickly on those cases that you don't need to move on. But nonetheless, there can be a case where you have a choice between either removing a section of a fallopian tube that's in immediate risk of bursting and causing the mother's death, likely death, or and in that process, you'd also be removing a baby from a place where it is but not viable. Like the baby can't reach full gestation in
Sure.
a fallopian tube. And there's no easy way. I've always wondered about this, but there's no easy way to transfer that baby. Like there's probably could be if we put enough research and time into it. But right now there is not. And so you're allowed morally to remove the fallopian tube, which is in danger of bursting, with the knowledge that the baby within the fallopian tube is going to die, but knowing that that effect isn't, in fact, desired or pursued. It's just another effect of the action. So the action that you're doing is a good action. You're saving the mother by removing a fallopian tube, which is in danger of rupturing. And you're doing it to save the life of the mother. It just has this unintended bad effect, and it has to be an unintended bad effect. You can't intend the bad effect, which is to cause the death of the fetus.
Yeah.
And the church says that's allowed. And so this would be, if you were drawing assistance from the mother, would be very similar to that. You'd be saying, well, we're letting the mother's body die. The gravity would not be the threat to the mother's life. In this case, and this is another issue, the gravity would be the amount of money that's going to be spent to preserve the mother's life is a huge amount of money. And it would seem disproportionate to the viability of the baby, the chance of the baby to live, because there's obviously it's worked out relatively well, although I hear there's lots of issues with the baby they're seeing prenatally now. So it's not abundantly clear. We don't have a lot. What everyone should know is there's not a lot of information that the public has on this case.
Yes.
So you're inserting and filling in things, and it's always speculative when you're doing that. You can be really wrong because you don't know details.
But I think this double effect is so misunderstood by Catholics, non-Catholics, believers, non-believers. I know I get beat up in social media a lot. It doesn't bother me, but it's often over this topic. So they'll say, oh, you're a pro-life OBGYN. You would let me die from a ruptured ectopic, which is obscene. I think we know that. It's absurd and obscene, but yet it's a failure of understanding this principle of double effect.
Yeah. And so you can choose the good action for the good reason, even knowing the bad effect is going to occur, as long as the gravity of the choice is equal. In other words, there has to be equal or disproportionate gravity towards one side or the other. So in this case, you have the life of a mother, life of the baby. So there's equal gravity there. So you can choose to save the life of the mother because it's equally grave.
Yeah, I've often, and many of us in this field have been accused of, inappropriately prioritizing the mother of the life over the mother of the baby. I'm thinking of the case where maybe there's severe preeclampsia and at 23 weeks of pregnancy, and I choose to deliver the baby because the mother is becoming so sick that her life is threatened now. My intent is to save the mother's life. If she dies, the baby dies. So it's not as though her life is more important, but in that setting, it's the driving decision maker. But it's so poorly misunderstood, and then it's twisted by those who want to attack people like us. But that's another story altogether. So it would not have been ethically inappropriate based on all these assumptions that we're making. The biggest assumption is this definition of brain death, but it would have been appropriate potentially for the family to have removed support and allowed her to die from what she was dying, which would be the brain injury.
Well, this is where it becomes a little more gray. I think so. You have to kind of look at this question from two perspectives. If she's brain dead, then there is no harm to the mother
of staying alive, because she's not alive.
Because she's not alive. So you're going to argue she's dead, then there's no harm to the mother. So the moral question, and this might seem crude or harsh or difficult, but the moral question becomes how much money and resources you're spending to preserve the pregnancy. Because I speculated before we came on that it'd be $5,000-$6,000, and you're like, no, probably more like $15,000 or $16,000 or more $1,000 a day.
Oh, easily.
So I mean, let's say we're talking at least 25 weeks at $20,000 a week. That's $5 million.
Yeah.
Is my numbers right?
Well, I can't do the math that fast, but I think you're close.
So $5 million is a lot of money that provides a lot of medical resources for a lot of other people. And it's just the reality of the world that you have to decide what is the appropriate allocation of resources for care. And if that's appropriate allocations of resources, particularly because there's a lot of question marks in the beginning of this, whether that's even going to be successful or not. You're not talking like $5 million and you know you're going to have a healthy baby born at the end of this process. Yeah. Because if a mother is actually, and this is where you kind of wonder about the brain dead, how brain dead is brain dead. Like the body doesn't sustain itself very long when there's complete and total brain death, even on machines.
Yeah.
So there's a big question mark of, is she actually going to be able to continue to sustain it? Because there's definitely an ability, as you know, when a woman's body is in stress, to naturally miscarry, to naturally abort the baby, because when a mother's body's in extreme stress, it will actually often lose the baby to preserve the mother's life on its own.
Back to the financial discussion, do you think viewers would be surprised to hear a bioethicist bring up economics? Or maybe a better way to say it is, does the question of economics often come into bioethical decision-making?
Not as often as it should.
Ah, interesting.
In the U.S., we spend an immense amount of money on medical care, and it is disproportionate probably to what should be spent.
Yeah, no argument from me there. How would you respond to maybe someone that would say, oh, you're putting a value on the baby's life. You're saying it's not worth $5 million. I thought you were pro-life. How do you think through that?
I'm putting a value on other people's lives.
Resource allocation.
Resource allocation.
Yeah.
There's a limited number of resources, and they've got to be allocated somewhere.
Yeah. And I think people might be surprised to know that has to happen in hospitals every day. It's not as public as this case, obviously. And to bring up a bad time during the COVID pandemic, it happened every day. There were 5 ventilators, there were 7 patients. We had to decide who got the resource and who didn't, because the resources were scarce, and they're always scarce to some degree or another.
We struggle in our very affluent society, and we are by far the most affluent society, relatively speaking, of any culture ever in the history of the world. Overall wealth is just insane, that we can spread medical expense through insurance, Medicare, Medicaid, other people, health insurance systems. We can spread the expense so that people can have an immense amount of money spent on their health care that is far disproportionate to what they could afford, and probably disproportionate to what is reasonable to spend. Like what we spend on healthcare in the U.S. overall is not a reasonable number. I think I've read that they're predicting within 10 years, 30% of the expenses in the U.S., I can't remember what the exact word was going to be, towards medical expenses.
Yeah.
At current rate of inflation and current rate of medical inflation, which is about 4 times faster than, I think, the average rate of inflation. Medical expenses are going up that much faster.
And to make it worse, we can't
hold
up.
By the way, as a caveat, all these numbers are just my general recollection, so don't rely on them for any research purposes.
Sure.
The numbers are huge.
Yeah. But what I was going to say is, to bolster that argument, we can't turn to our outcomes and say, well, we spend all of this money and look how great our outcomes are, because they're not. We don't get much for our money spent, sadly, when we look at our worldly neighbors.
So you'd have to look at the case also from like, what are the resources being allocated to the case? And you can't do that on ethical decisions. You can't do that in hindsight. So I'm saying you'd had to make that decision at 9 weeks, not at 23 weeks, where now it looks good. And it looks like that was a good investment, because a little baby is definitely worth $5 million. So, but you didn't have a guaranteed outcome. You still don't really have a guaranteed outcome of that.
Right.
So
interesting.
And people want to say that you can't put a price on life, and you can't, as far as what it's worth in the eyes of God and how we should uphold it in dignity. But if you ask people in the world how many are willing to pay $5 million to adopt a baby, there's a lot of people who would like to spend $5 million to adopt a baby and would if they had it. But there's a lot more people who would not spend $5 million to adopt a baby.
Sure.
And that's just the reality, right? You just don't have that money, so you can't spend that money. because you don't have it.
Right.
So
How
I'm not
does
death of anyone, by the way. I think if this baby survives and can be adopted, it's a wonderful, awesome thing. And it's a privilege of our very wealthy society to be able to do that. But there are literally places in the world where they can't afford $30 worth of antibiotics to save a baby's life either.
Mhm.
That has to do with allocation of resources.
How does this discussion change, or does it, now that this baby has reached what 23 weeks is sort of considered now a viable baby? If I delivered tonight a baby at 23 weeks, the intensive care unit team would attempt to resuscitate and save that baby. Does this discussion change now that we're at a viable age for the baby?
For sure, because now you're talking about the same sort of measurement of economics, right? So this is where economics becomes a big part of it. Is it cheaper to put that baby in intensive care and neonatal intensive care, or is it cheaper to continue life-sustaining treatment? Life-sustaining, it's really hard. Like body-sustaining treatment within the mother and take that gestation to a place where you wouldn't actually necessarily need neonatal intensive care unit, because that care is also very expensive and the outcomes are very questionable.
Yeah.
So
if we were in an academic setting, this discussion would be easier or cleaner, you might say, if she had rolled in at, say, 28 weeks of pregnancy.
it'd have been very easy.
Yeah. But it didn't work that way. But it would be easier. But now that we're there at viability, I'm hearing you say that there is a case to be made for we are going to keep this body functioning to get this baby as close to a safe gestational age as we can.
Yeah, and that's going to also be a medical call, right? As you made a point, like if her body's not doing the mother's body's not doing well, then you're going to actually deliver that baby earlier to put that baby in a safer space.
Yeah.
But if the mother's body is doing well, then you're going to keep the baby in the mother's body.
Yeah.
I would guess it probably similar expense would be my guess. Neonatal intensive care is very, very expensive too.
It is.
So my guess would be probably similar cost one place or the other. And that's where then you have this easier decision, right? Because it's the equal allocation of resources.
Yeah, I see your point. Yeah, I mean, but now we have the case that we've been given where now we are at viability, where at 9 weeks we wouldn't have been. And then again, it all gets back to this difficult definition of death. I think most viewers would be surprised to learn that there's really not necessarily a universal definition of brain death. After a car accident or after a stroke or something like that's difficult.
There are tests that I think states mandate to do before, but I don't think they actually require a flatline EEG on all things.
Yeah.
This is a better question for guys in the emergency room than it would be for me.
Yeah. I mean, I think the difficult scenario that people hope they're never in, but they are, is, there's a car accident and it's an overwhelming injury and their loved one is on a ventilator but has suffered, an injury, maybe a brain injury that's not recoverable. But they could be kept alive on the ventilator for a long time. But as you pointed out, they're not going to survive. They're not going to heal. And I like the way you said be allowed to die from what you're dying from. They would die from the brain injury. So removing the ventilator would not be the cause of death. It would be from massive brain injury.
Because their body's incapable of breathing because of the massive brain injury.
Yeah. Yeah, I mean, the trouble is, of course, these are always so emotional, and I hope no one was ever in that position. But we know in this very moment, someone is in that position.
No, and I apologize if people are listening to this think I'm kind of clinical or cold about it. I don't intend to be in. I try not to be in pastoral situations, but sometimes you just have to kind of look at the situation more objectively, not subjectively, to come up with the right answer, and then be subjectively present to the people who are in a lot of pain and a lot of mourning and a lot of loss. Because the level of loss and pain doesn't change the moral question.
Right. There's still the issues. They're objective issues.
A lot and painful doesn't necessarily mean it's wrong.
So I think this article that I pulled from NPR, their digital side, says there are 20 states, I believe, that have so-called heartbeat laws. that in one way or another are saying that an elective abortion beyond a very, very early part in the pregnancy can't be done in that state. And I think most of us in the pro-life community would call that a victory for the pro-life movement and decreasing the number of abortions. But I don't think this scenario probably was envisioned, when people were advocating for those laws.
No, I mean, there's a lot of things they don't envision when they're making laws.
Yeah.
It's hard to see or foresee those things.
Yeah.
When you have to make laws like this, I mean, it's just the reality. When you're having to define human life and what it is, and it's not generally understood, like
Yeah.
this is what human life is, then your society's not in a good place.
Yeah.
I can't remember who did it. You would know probably faster than me because I'm not on social media very much. But that guy who did a film or What a Woman Is, what is it?
Oh, what is a woman?
What is a woman?
Yes.
What is a woman? Right? Like when you can't agree what a woman is,
You're in trouble.
I mean, society's not in a good place, and you're not going to find a cohesive understanding of what medical ethics is or moral theology is. When you can't agree on the most basic things, there's no ability to dialogue or to accompany people. Like when there's no basic understanding of human life is this. And this is one of those difficult things. Like I struggle with the definition of brain death as death for this very reason. Like brain death. So death from a philosophical, theological perspective, death is when the soul leaves the body and there's a loss of integration, right? So the body is no longer capable of integrating itself. And usually you can say that when someone has zero brain function, zero flat line on an EEG, that they're no longer going to be able to control their bodily functions and their body's going to disintegrate, die. But then you get a case like this where I'm going to assume that she's got total flat line in her brain, and it doesn't sound like they're using, it sounds like basically just a respirator from the article. I don't know if there's more going on, but it sounds like from the articles I've read, it's a respirator that they're talking
we'd
about.
probably have to presume, hydration and nutrition as well.
Nutrition, hydration, and a respirator.
Yeah.
And her body's still functioning.
Yeah.
So,
which, to your earlier point, I think it was interesting. An actual absence of the brain, the body doesn't last indefinitely. It's not like a bad movie where it could just be sustained forever and ever. Things begin to disintegrate and just come apart.
So, and also brain alone is not the nervous system. I should have said that earlier. Brain alone is not the nervous system. The nervous system is a whole system that includes all your nerves, your spinal cord, and all your nerves together. And as everyone knows who's ever had their knee tapped with the little hammer, like not all those decisions get made on the level of the brain.
Sure.
Not all the neurological decisions are made on the level of the brain. Your nervous system functions as a whole, and your nervous system can take over functions for the brain when the brain is not working like it should. So you could have a very highly damaged brain, and the nervous system is still holding itself together, which would actually be a sign of life, right? On a philosophical level, it would be a sign of life, that the nervous system is still functioning and still operating and still sustaining the body. That would be an indication that maybe not dead.
I think I've been in a position to observe patients die. Fortunately, not many through the years, but some. And it's always amazed me that, in one instance, we would say this person is alive, and in the next instance, whatever measure of time that is, a millisecond, they're no longer alive. So what is it that changed from the first to the second? And I think those of us who are believers would talk about the absence of the soul and the departure of the soul. Those who don't come from a faith-based understanding of life, I'm not sure how they work their way through that. Because what changed? There was something and then there was nothing. That life force, whatever you like to label it as, is gone. And it changes in an instant.
Yeah, and I mean, as you know, and as those same people in the scientific fields know, when your heart stops beating, you don't die. When your brain stops working, you don't die instantly. Like there is a aspect of our bodies and our souls that keep working, keep operating. Uh, Eventually, obviously, you do. Like, you're not living long without a beating heart.
Right. But
Not living
some
long at
amount
all.
of time, yeah.
But it's not like if my heart stopped beating right now, God forbid. But if my heart stops beating right now, it's not even like I would stop being able to speak.
Right.
I would feel something. I could probably say a few words before
Mm.
I started dying, right? Like,
Right. Anyone that's witnessed CPR that was successful knows that the heart can stop and the person doesn't die, fortunately, for a few minutes. Yeah.
the brain can stop functioning, and the moment of death is really, it's a theoretically impossible thing for medicine to determine, because the medicine can't see or experience or measure the soul.
Mm.
So what you're actually trying to do in medicine to determine death is determine that the body is disintegrating.
Uh-huh.
The word works both ways, but that the body's no longer able to hold itself together.
Right.
Um,
If we
so-
if we return to the abortion question, because I feel like maybe there's a thing that's floating out there that we should probably speak to. We were talking about economics as part of a bioethical decision. How do we answer the argument? This single mother who finds herself pregnant simply cannot afford to buy food for this baby or can't feed her other children if she has this baby. Therefore, there's an economically based argument for it's appropriate for her to have an abortion destroy this pregnancy.
Well, I mean, the difference would be just what you said, which is destroying the baby, right?
The intent is to destroy it. Yeah.
The intent is to destroy the baby. What we're talking about in this situation is no intention to destroy the baby. The intention would be to allow the mother to die or continue dying or finish dying, or
Yeah.
and this is where it does become like a real issue, because if the mother's actually dead, then there's no, as long as you're treating the cadaver with respect, there's no moral issues towards the mother.
Because she no longer exists.
She's dead.
Yeah.
So you just have to respect her body, the cadaver.
Mm.
You have to respect the body with the dignity that it should be treated with, but there's no moral issues towards her at all. Now, if she is alive in some way, then the question becomes, what level of treatment would she want? You have to presume what level of treatment she would want and what level of intervention she would want in order to sustain her pregnancy, sustain her life to the point of the end of the pregnancy.
Right.
Like, that would become an issue if you're presuming that she is still alive. But if she's actually dead, then her intention doesn't matter anymore.
Yeah.
Because it's just a cadaver.
Yeah. I mean, I'm sure the parents wish that level of understanding had been present at the moment. But of course, as they point out in some of the subsequent interviews, now, of course, they're struggling with the topic as well, because now they have a viable or a potentially viable grandchild that suddenly now the whole equation has changed.
And this kind of goes back to the child was a potentially viable grandchild at 9 weeks too.
Right.
Right?
Yeah.
But if you just sustain the pregnancy.
If nothing else, this demonstrates, it seems to me, how incredibly important life is. I mean, look what the discussion of life is causing all of this, because no matter what side of sort of the aisle you reside, life is a big deal, simplistically, isn't it?
It's a tremendous gift.
Yeah, and deserves respect.
So, assuming that, I mean, I think if you want to take the case that the mother is still alive in some way, even if not functioning on a brain level, I would presume that most mothers, not maybe all mothers, but most mothers, knowing that if they had, so she's got zero neurological function, but still alive, which is...
That's tough in its own right.
I mean,
yeah.
It's tough, but if we're just going to hold that, right? There's zero neurological function, but she's still alive. Then there's no pain and there's no physical suffering of any sort. So if you ask the average mother if she were in that situation, would she want her body to be sustained for her baby if there was going to be no pain or no physical suffering in order to complete the pregnancy? I think most mothers would say yes.
I agree. I've seen that time and time again. Yeah, mothers will,
Even when there is pain and suffering,
right.
I think most mothers say yes.
Yeah, mothers will do amazing things of self-sacrifice to save a baby.
So I think there's another way of looking at the case, which is assuming that on some level she's still alive, even if with vastly diminished neurological function.
Mm-hmm.
And if that's the case, then the question is, what would she want for herself and for her baby? I don't think it would be inappropriate assumption to say that she would want to sustain the pregnancy as long as she could, because at that point in time, that's the one thing she has still to live for. Because she's not going to function on any other level, but she can function. She can give her baby this gift.
Wow. Yeah, I mean, it will be nice at the end of this story if the punctuated sentence is, a child is born alive and survives.
And happily ever after, yeah.
Yeah, I hope it turns out that way. Of course, we don't know, but we'll see. We'll keep following this story and see. So, as we sort of wind down, are there closing takeaways for listeners that have been struggling maybe with these bioethical topics that you can share?
So there's ethical questions and there's theological questions. And I'm going to part from ethics a little bit and just from a theological perspective. St. Augustine, who I have a great affection for so many reasons, is often misunderstood and misquoted. He's not misquoted, he's misunderstood because he does say actually, love God and do what you will. But what he means by love God is actually love God, not just have happy feelings towards God and you can do whatever you want, but actually, if you're loving God and giving yourself completely back to God in everything you do, then no matter what you're choosing, whatever decision you're making, as long as you're doing it because you truly believe that it's for the love of God. And remember, Christ tells us, if you love me, you will keep my commandments, right? So this isn't an empty sense of love. This is an active giving of yourself to God through loving him. But if you're loving God and trying to do things all for the love of God, the decisions you make in these moral cases, in these ethical cases that are hard and difficult decisions, don't matter. Like, you can make the wrong decision. And as long as you're attempting to make the right decision for the right reasons with as well as informed conscience as you can get, you can't be held, and you're not held by the Lord to perfect knowledge. So in so many of these cases, it is hard and difficult to know what, because we don't have perfect knowledge. It's hard and difficult to say what will happen, what's going to happen. As long as you're realizing that I'm doing this because I love God, I respect his commandments, the way he created the world, and I love the people with whom and for whom I'm making these decisions. And you can say that from a place of prayer and from a relationship with the Lord and a knowledge of what the church teaches. It doesn't matter if you make a mistake. And it doesn't matter if you make a mistake and someone dies as a result of the mistake. Because you did the best you can with the most love you can. This is Augustine's The Great Power of Love God and Do What You Will. I mean, you're a doctor. I say this not so often to doctors, but to young nurses. I'm like, you're not a real nurse until you've killed somebody.
Oh, gosh.
When I'm giving the preparation, the ethical preparation, they're like, "Father, it's awful." I'm like, no. You're going to make a decision at some point in time that's going to result in someone dying because you're a nurse.
Yeah.
And you may have made the right decision, but it's still going to cause their death, particularly if you're a nurse working in a hospital. Any sort of unit with more intensive care, I don't want to say intensive care unit, but more intensive care, there's going to be a decision made, and your immediate physical action is going to be at least partially responsible for someone passing from this life to the next. And if you're loving God and doing the best you can to love God, to respect that person, love that person, whether it's a mistake of the doctor, a mistake of your own, no mistake at all, you gave the right treatment, but the right treatment because of unforeseen circumstances proves to be the wrong treatment.
Sure.
Then you did nothing wrong. And you loved that person in a time in which they were suffering. And that's what we're responsible for, is loving that person in the time in which they're suffering, loving that person in time in which they're vulnerable. And the mistakes happen.
And we're back to intent, aren't we?
Yeah, we're back. It's not all intent. Like I said, if you love me, you will keep my commandments. You just can't do whatever you want. You have to understand that love actually has content to it. But I just want people to understand that in these hard and difficult situations, because I've walked with a lot of people at end of life decisions. And you and I have talked together on different cases where we've walked together with people who are in different places in preeclampsia and different places in other pregnancy issues. And they're trying to make hard decisions about baby's life and mother's life and danger of the baby. And do we deliver now or do we wait? Is the baby safer now or safer later? All those decisions. And then in hindsight, people think to themselves, wow, that was the wrong decision. And then they beat themselves up for it and they think they've done something horrible. And you just didn't have hindsight until after it took place and you did the thing you could do with the most love you could do. And that's really important in these situations because then you never make a mistake. If you're doing your best to follow God's commandments and to love the person and respect and show dignity to the person you're with, you never make a mistake. Morally, you never make a mistake.
Well,
you make a mistake and you learn from it, but you never make a mistake.
That seems like the best takeaway we could possibly gain from this. When I hear you say that too, I'm reminded that honest people can disagree. We're looking at this case and we're questioning some of the assumptions. We don't know the details, and we're making a bunch of assumptions, but we don't have an agenda in our discussion other than to understand. But in so many cases, it would seem today, social media being what it is, we seem to have lost the ability to recognize that two good people could come up with a different conclusion, and that's okay.
No, it can. It can just be it can be simply a different in perspective. Like somebody may be thinking, when I said, the $5 million number, they may be thinking $5 million, that's not a lot. Another person may be thinking $5 million, oh my gosh.
And they're both right.
And they're depending on the perspective and where they're coming from, and they both can be right. And if you don't have $5 million, $5 million is all the money in the world. And if you have $500 million, $5 million is a drop in the bucket.
Well, thank you for trying to shed some light on these difficult topics. I know that you, as you always do, you've provided some comfort to people that are struggling with the topic. I know you make me feel better about it, so thank you. We really appreciate you. You're a great and holy man and a wonderful friend, and thank you for participating.
I try to be all those things. Pray for me that I can become all of them. And I'll be praying for you and the hard decisions you make and the great witness you give in your practice.
Thank you, Father.
Welcome. God bless.
And God bless you. Well, I hope that you've enjoyed this discussion. As I said at the beginning, I fully appreciate and recognize that this is a difficult topic, and I know it is going to generate some angst and probably some less than healthy discussion and comments. But please comment. Please ask questions. I'd love to have the chance to respond. If I don't know the answer, I'll get counsel from Father McCarthy and try to get you the answer if you have an honest question. Please remember my last point, and that is honest people can disagree. And if our motives are good, as Father pointed out, we're okay. And try to assume good intent and people that you may find yourself disagreeing over these topics. This is a hard case. There's no question about it. Part of the hardness is being made worse, I should say, by misinformation, incomplete information, and people literally trying to make this something that it isn't. You can't read about this case anywhere online and not feel that it's coming from an abortion standpoint because of the so-called personhood or heartbeat law in Georgia. Many people are using the existence of that law as a way to say it's creating harm, and this case is an example. We now know that law was not creating this case. What created this case was a misunderstanding of that law, and people acting in a way that was inappropriate because they thought they were acting properly because they misunderstood this law. That's not the law's fault. That's the misunderstanding of the people, and that's where, if there's a blame, that's where that blame lies. I hope that you take away that this concept of brain death is not straightforward. We don't have complete information in the media. I don't think we're going to get complete information on that. The hospital, Emory Hospital, has not commented beyond really superficial sort of responses to anything that I can find. So maybe let's all recognize that it is a difficult topic, that we have incomplete information, and that sometimes what we're reading is being written by those that are motivated to make us think in one way or another. Also, I think we have to recognize that this show's about women's health, and this patient's mother, Adriana Smith, her mother is struggling. I think I can't imagine the pain that her mother has been through, first with losing her daughter to this tragic event, and now the complex combination of emotions that she's feeling now about a viable grandchild and the life that represents. So let's pray for that family and for the decisions that they have to make and the pain that they have to endure. But thank you for joining us. I hope that you've enjoyed this topic. Please write me about this. I'd love to hear your thoughts. I'd love to hear if you would love to hear more about similar topics. If you have questions, as I mentioned, please send them to me. I'll do my best to respond as quickly as practical. I hope you'll like and share and subscribe to All Things Women's Health and share it with everybody you know. That helps us continue to make great content. I want to thank our friends at the Holy Family Birth Center. That's FortWayneBirthCenter.com. They own the studio and they support the podcast, so thank you to them. I'll be back again soon with another episode of All Things Women's Health. I'm Dr. Chris Stroud.